Well, listen, this is a very personal, special day for me. I was a graduate student at the Kennedy School in 1997, and I used to ride this M2 shuttle bus that would take us from Boston by the Harvard Medical School
Right.
to the Kennedy School campus over in Cambridge. And I had the opportunity of often traveling on this bus with this graduate student who was taking courses at MIT practicing ER doc, who had this fascination with information technology. And we got to build up a friendship, and I got to observe his stratospheric rise in the healthcare industry, and that would be our very own Dr. John Halamka. I remember fondly the first time we had met. The Beth Israel and the Deaconess had announced a merger, and one of the challenges was they were going to consolidate the ERs, and the records across the street were not physically compatible, or the systems weren't interoperable. Right. So there was a quandary as to whether or not they should build one mega database to rule them all, or whether there was an alternative path to open up, allow physicians to see the records from the other ED and allow them to rationalize. John was just a whippersnapper. He kind of decided to take matters into his own hands, and for a whopping $50,000, he built a very, very thoughtful web-based platform called CareWeb. I want to start, actually, John, why don't you just tell him a little bit about what you did, because it's the spirit of frugal engineering, which might be the beginning of the conversation we're going to have. John, what did you do with CareWeb back in those days?
Well, so at that time, the institution said, we're going to spend $50 million and put in a giant single integrated system. Because this idea of web-based, cloud-hosted, virtual data flowing based on standards, too hard. So I had 2 weeks and a budget of $50,000. It went live. It affected care. Fast, cheap, web-enabled, or $50 million on client-server monolithic takes 5 years, and the physicians hate it. Let's go with the fast and cheap.
Well, the punchline is John gets asked to be the chief information officer for the merged entity, and he goes on to serve our great country, first under President Bush on the standards. He chaired the standards panel, and then again under President Obama. So this is going to be a lot of fun today.
Good.
We're going to dive into how we move towards population health, but the foundation on a more robust technology platform. I had the pleasure of serving as Chief Technology Officer, and I'm more excited about the fact that my successor is my brother-in-arms, Todd Park. And together, we had been on a journey of opening up government data, and we put forward a fairly simple hypothesis about where we are. Today is the absolute best time to be an innovator in healthcare. And we believe this to be true because of these very important trends. Number one, we're opening up government data, and we're starting to see the private sector open up as well, which is creating liquidity, which is fueling a whole new class of products and services. Second, we're seeing a wave of new incentives come into the healthcare system. First, to drive the adoption of electronic health records, but more importantly, to impact how we pay for care. And the combination of the opening up of data and the incentives is leading to this thesis for why we're seeing such incredible innovations in healthcare today. I want to begin with the notion of open health data and ask John to comment a bit about where we're going. I assume by now you've heard from Brian, you've heard from Claudia. I presume you've been familiar with the open health data movement. Fred, I'm sure, has inspired many of you with what he's done on DocGraph. The premise is that the taxpayers have invested heavily in building up all this data asset, and that it should be made available to the American people and, frankly, to the world in machine-readable form. This is now not only a vision that the president put forward on his first day in office, but we're now starting to see the implementation, legal structures, if you will, that follow. And the stories are endless, but I thought I'd highlight just one on this example, highlighting the importance of Blue Button and the fact that consumers should have the ability to download in safe, secure formats their own health information. John, you sit on the standards body. You're thinking about how information will flow across the health system. Could you talk a bit about where we are today and where we might go in enabling the safe, secure, not only of downloading, but then sharing of that health information? Where are we going?
Sure. So in healthcare, many professionals, policy and technology, have said, healthcare is different. We can't actually look at consumer-grade technologies or industries like financial services. Healthcare is different. Well, I would argue that's just not true. And so why did the web take off and transform society? It's because we had HTTP and HTML. How do you get data from place to place, and how do you represent it? Well, in healthcare, we've spent many years creating standards, and that was good, and we did foundational work. But if you look at where we need to go in the future, if Google or Facebook or Amazon were to do healthcare data exchange, would they build 1,000-page implementation guides? Probably not. They would use simple RESTful approaches. How do I use URLs secured with technologies like OAuth 2 and OpenID to get data from place to place? So fine, in meaningful use, we have created a set of technologies based on industry standards, and that's foundational. But I think the next stage of meaningful use will embrace the Google, Amazon, Facebook approach, especially for data transfers to consumers. And we really need to focus on consumers. I mean, my father died 6 months ago, and I had the challenge of coordinating his care at the end of his life. Getting the data from hospitals and providers into the hands of consumers, where then it can be enabled with these innovative apps you've described, is the secret sauce, the catalyst to breaking down this notion that healthcare is different.
Well, let's just provide some context to the audience as to where John was describing this. So in the High-Tech Act, as many of you know, we put forward a set of incentives, roughly $26 billion, to drive the adoption, but we had done so in a 3-staged process. The premise being we would want the industry to improve as time evolved. So in the first round of the Meaningful Use program, we simply had the premise that data should be accessible. And people often did that with PDF files or with some other USB sticks. We're in the middle of stage 2. You might want to comment a bit about what view, download, and transfer requirements might mean, but we've done a little bit. We've provided at least one technical standard, the direct protocol, for the transport layer. Right. And what John is describing is where we might go in stage 3 in terms of making sure there's essentially an API for healthcare. Is that a fair characterization?
Right. So with stage 2, which really takes effect for hospitals October 1, for physicians January 1, 2014, it says, hospital, doctor, you want a stimulus payment? I will not give it to you unless 5% of your patients actually go in to the technology you provide and look and gather their data, and securely communicate with their providers. So these standards suggest that, any of you, can go to your doctor or hospital and view, here's my med list, problem list, labs, download, but I got this cool app that was just engineered on my iPhone. I want to send that data to the cool app in the cloud. You need to be able to do that too.
So what we're hearing in this early segment is that the movement of data liquidity is driving more and more to the world that we see today in the consumer web. That is very positive, and I think there's plenty of room for public comment on this journey. So as these conversations evolve about how we drive towards essentially a set of APIs in American healthcare using the Health IT Standards Committee process, we would, I'm sure, welcome public input along the way. But if you haven't, you should check out John's blog to get an update. Every single month the Standards Committee meets, and he does a wonderful summary as to where we're going. Now, I want to shift a little bit. It's too easy to simply say we're going to fuel a series of apps or products and services with all of this data. It's a shorthand. We all know in this room that it's not about the app. It's about the service that might be powered by technology and the data that we're describing and other aspects of innovation. But it's the building up of a service that actually is put into practice that will have real meaningful impact in healthcare. So I want to give you just one personal example. So we at the Advisory Board Company, we have a platform called Crimson. Crimson is our population health analytics platform. And Crimson today is at pretty big scale. We have 1 out of every 4 hospital patient discharges flowing through the data vaults at the Crimson platform here at the Advisory Board. And as we move towards new payment models that are penalizing folks for readmissions, payment models that reward population health, we're seeing demand among our hospital members for products like a real-time service. So here's a snapshot of Crimson Real-Time. And one of the basic premises that on discharge, hospitals should have a better sense for which patients are at higher or lower risk for readmission. And we should be able to use all the available data, public and internal, to help determine that predictive model. So you can see an example of what we provide to frontline workers in hospitals to give them a sense that on today's discharge list, patient X versus Y is at a higher risk of being of readmission, and so you might want to be a little bit more focused on the discharge planning instructions or the nurse case management engagement strategies. But it's not an app, it's a service that allows you to fuel better decision making by frontline workers. And so we're seeing the payment changes in healthcare lead to the creation of new products and services fueled by a lot of that open data that we described, but they're not, the data in the app itself is insufficient. It's got to be part of a care flow redesign, a service that's released. So, John, I'm curious, you obviously, as CIO for BIDEC, you must internally have a kind of a readjustment, if you will. What are you building or redeploying in light of payment incentives? Talk a little bit about, A, where are you getting payment incentives, and B, what that's led you to build.
Sure. So the Affordable Care Act, all politics aside, is about paying for quality and outcomes and longitudinal wellness rather than episodic sickness. Now, hospitals know how to take care of you really quite well when you're sick. Do hospitals have any idea how to care for you when you're well or to keep you from coming to the hospital? Not really. So we've had to build, as you suggest, readmission reduction applications. And our attempt, oddly enough, is to do prediction of readmission on your admission. On the day you come to the hospital, can we predict, are you at risk for a readmission when you're discharged?
Wow, well done. Touché, John.
There you go. So we have a CIMI grant, a CMS innovation grant to do that. But importantly, we focused a lot on care management and population health. So we've built a community-wide quality data registry, taking data, because of data liquidity, from multiple vendor systems, inpatient, outpatient, ED, normalizing them, consolidating them, and providing these dashboards that non-physician extenders can use to say, Mrs. Smith is a diabetic. Let me look across the community. I see Mrs. Smith hasn't had a foot exam, an eye exam, hemoglobin A1C is up, glucose at home is trending up. We better actually do a home care visit. We think she's eating Krispy Kreme for breakfast, lunch, and dinner, right?
That's not healthy?
Yeah, bad.
Oh, come on.
And therefore, we are putting our money not into building bed capacity, but actually keeping people out of EDs and hospitals through home care and care managers.
And when you describe that phenomenon, I think one of the, big questions that we're grappling with is the healthcare infrastructure that's widely deployed today. How flexible or capable of it is it to, you've built a lot of this internally, right? So you have the freedom to kind of on the fly change what the tools are that you're making available. Comment a little bit from the standards committee standpoint. How nimble are our health systems today in being able to build or support these alternative products and services? Any reaction to the ease with which that'll happen?
Well, Meaningful Use Stage 2, as you described, really helps because it does mandate that every EHR, hospital and provider, send data, in fact, a whole litany of care transition information to either another provider or a third party. So what we've been able to do is get the vendors to emit this data that was previously a silo locked up inside their systems. Still imperfect. I mean, healthcare data is actually of not the greatest quality, it turns out. 3% of the time, the gender is actually wrong in the registration record. A lot of cleanup to do, but it's been able, over the last couple of years,
Is that really true? I didn't realize that, John. You just messed me up here. What? The gender's wrong?
Well, I mean, come on. It's a binary field. Well, actually, there are 27 different variants. But it is sometimes, when you look at data in healthcare, it's not uncommon to see women getting prostatectomies and men having babies. You have to actually run a lot of data cleanup filters once you aggregate the data in the community to make sure it's usable. Mm-hmm. So the federal regulations have really enabled us to build the foundational components. It's still very much a work in process, huge entrepreneurial opportunities for business intelligence systems, data cleanup systems, and aggregation systems.
I want to pause on this because I think it's an important question for those of us in the audience, and that is, will the world be one platform to rule them all? In which case, every one of these, whether it's readmission calculators on admission or readmission calculators prior to discharge, or any one of a number of other examples that you've cited, will all of that be done in one system? You're describing a world where the data will be more accessible to third parties. If I was in the audience today and I was wondering, hey, can I catch a file from kind of the EHR systems that have been certified for meaningful use, can I really build a reliable service on that stage of meaningful use? I know that is the aspiration.
Right.
I believe it to be true. One example is here in Boston. We, when I was back in the administration, we had funded an R&D program right here in the Children's Hospital with Ken Mandel and Zach Cohane. And the idea was to create a smart platform, basically a wrapper that sits on top of these legacy certified EHR systems. And the test case was, we did a little app challenge, and the test case was, could just on pharmacy data alone, could we allow a third-party app to just speak once to the platform and then have it sit on multiple EHRs? Could they actually run effectively, despite the gender variable thing you're describing? And it turns out that it worked. I think the winning app was Meducation, a service that basically said discharge instructions from the ED should be able to be translated in multiple languages. And so this was able to take the medication order and feed this basically discharge instructions by language app. Now, it's not like the world's most sophisticated population health,
Sure.
but it proved the point. There are skeptics in this room, John. Just comment. Okay, some of you are skeptics, I would imagine. How viable is this path that these guys can go raise capital, build a service, and feel confident that they can plug into these systems? Where are we today? On a scale of 1 to 10, where are we and where are we going?
Well, so I'll give you two trends. I'll give you a pessimistic trend, and I'll give you an optimistic trend, because we want to balance this for all those skeptics in the audience, right? So the pessimistic trend is you're actually seeing more and more mergers and acquisitions in healthcare. People believe that healthcare is going to get better by getting bigger, that we're going to somehow deal with ACA by owning all the means of production, inpatient, outpatient, ED, and that way we can control cost and quality. And when you become a giant, fully integrated system, everyone says, I know, one application for everyone, everywhere. So you are seeing the hegemony of a few vendors replacing a lot of these edge systems that exist today. So that's sort of the bad trend. But why is this platform, this happens to be an iPhone, but it could be Android, doesn't matter. Why is it powerful? It's because there are thousands of people in garages inventing modular systems that actually are cool and usable every day. If only Apple made apps, would we buy this? Maybe not. So I think the industry needs to recognize that the innovation and the creativity of the crowd is going to actually make, especially consumer-facing applications, much richer. So this idea of the smart platform, building an app store for healthcare that can sit on the Cerners, the Epics, the Meditechs, the ClinicalWorks Athenas, is really where we need to go. In fact, I could argue the vendors will sell more of their products if an ecosystem of modules around their products is rich, creative, and agile. So that's really where we're trying to, as a standards committee, look. It's not just data standards for one-time export and import. How do you build these interactive APIs that would enable this ecosystem of apps to evolve? I'm optimistic.
I'm optimistic as well, and I think what you're describing in the first comment about where we are going in stage 3, we might be on the lookout for that particular, call it an on-ramp, if you will, in the regulation. I want to talk a bit about scale. So a lot of what you hear, most of what I've been talking about over the last several years has really been about one-off great stories about individual entrepreneurs and innovators building incredible proof of concepts that really inspire you to think that the world's going to get better. And from the perch of the advisory board, I thought I'd give you a little bit of context around scale. So we, as I mentioned earlier, have a fairly significant window on the performance of healthcare today, and this is what I would have expected to see, but it was important to have the data kind of come out. We took a look at our member hospitals and health systems, and we tried to suss out how effectively were they deploying these tools to actually deliver results in reducing 30-day readmission rates. And the good news, after 3 years of implementation, is that we're seeing very, very clear success stories. But, and this is the most important point, it bifurcates on one very important variable. the degree to which providers engage in the service. For Crimson members, who are what we deem to be high utilizers, that is, they have more physicians on the front line engaging with the data, making better decisions powered by their ability to access this information. When the providers on the front line engage, utilization, the readmission rate falls, and falls considerably. Same technology at institutions where fewer physicians engage, we see no material impact. In fact, it goes in the wrong direction. The point being, and it's intuitive to all of us, you got to transform care on the front line, and all the apps in the world won't do a lick unless you've built a culture of engagement and participation. And just to give you an order of magnitude, the high utilizers on the Crimson platform have 6 times as many providers engaging with the data than the low utilizers. It's a 6-fold rate change. And I wanted to ask you, John, if you could comment a little bit about how important is frontline engagement on these tools to success? Is this an anomaly, or are you seeing this at the BID?
So this is absolutely what we're seeing. So in 2010, we actually mandated the use of a certified electronic health record as a condition of practice. Can't join our organization, can't do contracting unless you are engaged with the data. And this quality data center, this registry platform I mentioned, we've got a governance structure that is reviewing the data and the performance of every doc with every doc on a monthly basis. We mandated the use of personal health records. 2 years ago, we started sharing notes. Everything that a doctor writes about you is viewable by you. We actually changed our medical staff bylaws to require that. So as you say, the technology itself, fine, an enabler, but you need to change the culture, and you need to change the policy to incent adoption.
So I want to end a little bit with our final point, and that is this. Where are we going from here? So by a show of hands, how many of you have heard about the Care Transformation Prize Series? I can see the audience. Just raise your hand if you have. Very few. The advisory board company has partnered with Heritage Provider Network and the Bipartisan Policy Center to bring to you a network of prizes built on open data using the Kaggle platform. And we have extended the deadline to October 31st for any of you in the audience who represent providers who have access to the data, but not necessarily access to data scientists to help you mine and harness the full insight potential of your own data. We're offering a $300,000 prize series. You can visit the website caretransformationprize.com. caretransformationprize.com. The basic premise is this. We are inviting data holders to nominate questions they would love data scientists to answer. And we're looking for those data providers willing to sign BAAs with the highest performing Kaggle data scientists to actually go after this. Let me give you one personal example. When I was in government in Virginia, we funded a project. I call it Bundles for Babies. The logic was we looked at our map of preterm birth rates and found that the Shenandoah Valley had the highest rate of preterm birth. And there were no high-risk OBGYNs in market. And what would happen is the mothers would eventually deliver early. They'd have to drive an hour and a half to UVA, and high risk to the mother, high risk to the child, high cost to Medicaid, not the ideal scenario. So we funded a very small pilot. Could we pay for a high-risk OB to telemedicine in to a federally qualified health center in Harrisonburg? Over 3 years, we engaged with countless women, and we cut the preterm birth rate 25%. The question that I asked, that was funded out of a grant. If we wanted to change the payment system in America so we could fund a more intensive level of engagement, how might we better predict at the 12th week a pregnant woman who might likely end up with a preterm birth? Mm-hmm. And if we were more effective in predicting, might we then carve out a bundle, a payment bundle, to invest more during the care of that higher risk pregnancy to make sure that we have better outcomes? That's an example of a question that I'd like to pose. I'm hopeful today that as you look forward, you would join us on the caretransformationprize.com site, suggest your data sets and questions, and then propose whether you'd like to be part of this journey by nominating your own data to be safe, secure, HIPAA, BAA agreement signed to get the world's best data scientists to help solve this problem. Are you with me, John?
Well, so let me just tell you as inspiration to the audience, first, listen to him. But second, we have lots of data in healthcare, but we lack information, knowledge, and wisdom. So help us with that.
Thank you all very much. Have a great day.
Thank you.